So today we are going to review the early findings from the Yale Kidney Stone Patient Registry. So there are no financial disclosures to report. Initially, I'll start off by reviewing the epidemiology of nephrolithiasis just briefly. We're going to describe the Yale Kidney Stone Patient Registry, review some of the study findings concerning uric acid stone formers, and report some of the registry data concerning converters, and also describe the linkage between CKD and also stone formation. So the estimated prevalence for nephrolithiasis is about 10% for men and 7% for women. We do know that within 2 years of the initial presentation of an episode of stones, there will be a recurrence of approximately 11%. And that increases significantly to about 39% within 15 years. This is really born out of the Mayo Clinic data. So there is a known association of stones with CKD. Hazard ratio has been previously described as 1.67. However, the extent to which this relationship is being driven either by the stones primarily or CKD primarily really has not been elucidated. We also know that these stone formers have a significant high utilization of healthcare, and that's increasing the cost burden for these patients to our healthcare system. When we review the Medicare population and we're looking at the ED utilization rate, we see that 71 per 100,000 population of the patients with stone disease actually utilize the ED versus those overall of the Medicare population at 184 per 100K. This total cost burden is significant, over $2 billion, 1.5 billion of which is related to the inpatient and ED care. So this is important for us to actually address stone disease so that we can reduce this cost burden, which is the significant cost burden of the urology services to the medical healthcare system. And the individual cost burden is actually high as well, at over $4,000 per capita. So, and that being said, the Department of Urology and also the Department of Internal Medicine section of nephrology has been working in an interdisciplinary manner for quite some time with the Stone Clinic. And this allows for an optimal integration of both the medical management, surgical management, and nutritional management of those individuals with stone disease. This clinic involves urologists, nephrologists, and nutritionists to accomplish such goals. But despite this collaboration, we notice that there's a need for increased medical knowledge. For example, we want to describe what is actually going to contribute to the increased prevalence of stone disease. What are some anatomical procedural factors that can also result in stone disease and hinder or increase more efficient management thereof. And also the thought is to create this data repository so that we can look at those unknown factors associated with stone disease and the risk of recurrence. So that being said, the labor of love here, the Kidney Stone Patient Registry was created. So this is a data repository set that is actually stored in REDCap, and it consists only of adult patients with known kidney stone disease. So initially, the retrospective cohort was created, looking at all of the patients within the Yale New Haven Health System, EPIC EHR system. A full waiver of consent is, of course, obtained. And we estimate that we need about 1,000 patients for inclusion. Mainly, we wanted to first explore uric acid stones, but of course, this has been expanded. Prospectively, the component of this registry is to look at those individuals who are going to have surgical intervention and how we can actually best manage them. So we have about 50 patients that we estimate that needed to be included for the study from that perspective. So when we're looking at the retrospective design, this is not all the variables, but I just present this to you so that you can actually be familiar with some of the variables of the study. So we're getting a lot of demographics here, of course, age, sex, BMI. We're looking significantly at past medical history to include looking at the CKD stage, and also other disease states such as hyperthyroidism, gout, hyperparathyroidism, looking at the family history of stone disease, past surgical histories, including bowel surgeries, in addition to, of course, urologic procedures, looking at those patient visits and determining what was the medical therapy provided, dietary counseling as well, and looking at all of the chemistries that are associated with these individuals. That will be their urine chemistries and their serum chemistries. Finally, we are capturing imaging information. It's going to give us information concerning type, location of stones, and any other gross pathology of the kidneys concerning stone disease. Now, prospectively, when we look at this study, we're actually looking at the day of surgery and what's happening at the time of surgery. So capturing the surgery type, the past medical history of the patients concerning any antibiotics, labs, any intraoperative findings, as I've listed here, considering the dose of radiation that's given, shocks given, laser management, stent management, any complications intraoperatively that were noted, and finally, following those patients post-operatively well to actually determine if there have been any post-op complications or any residual stones that are found on imaging here, as well as capturing the data concerning that post-op management of the patient. So those are the retrospective and prospective components of this registry. So at a glance, at this point, there are several data points. As you can see, it's robust in its nature. Over 10,000 patients have been included, well beyond the initial 1,000 patients that were thought to be for initial inclusion. We have over 4,000 24-hour urine analyses that are from Lithogenic, Quest, and LabCorp, also a few from Mayo Clinic. And we have over 6,000 stone analyses for patients with many variables, as I mentioned before. So, as I mentioned, the first question that we wanted to explore in looking at this registry was actually about uric acid stones. As you know, this represents about 10% of the stone population, and there's many known unknowns. For example, how should uric acid stones actually be defined? So there was a definition put forth in a study that actually said that maybe we should look at these uric acid stone patients as those individuals who actually have a stone composition greater than 50%. Of course, they had a mixed composition, and that was controversial. So others have looked at stone composition at 100% to see if that should be the definition. So we aim to actually provide a definition of what a pure uric acid stone former is versus someone who may be impure for uric acid stone formation. Also, there has not been a comprehensive metabolic profile of the uric acid stone former. So we know that some of these conditions are associated with uric acid stone formation, such as hypertension. However, the relationship between gout and uric acid stone, that has not been well elucidated. There have been some studies that indicate a relationship, but in a gross meta-analysis, that relationship has not been borne out. So what are the biochemical characteristics, really looking comprehensively at the urine and the serum studies of this patient population? And finally, we're going to look at the evidence basis for dietary management and pharmacotherapy for this population. Really what happens in practice is that we are applying the management tools from calcium salt stone formers to uric acid stone formers. And most of the evidence to guide some of what we do pharmacotherapy-wise for uric acid stone formers really comes from the 1960s and hasn't been adequately updated. So we first start off by looking at this uric acid stone former cohort, and we stratified them. We noticed that there's greater than 4,000 patients who have the documented stone analysis. Of those individuals, 16.8% of them actually had a uric acid component present, okay? We did exclude some cases, only about 2%. Those were cases in which there was 4 patients that we could not actually 10 patients where we could not actually identify what their composition of uric acid stones was. Just the lab analyzer did not give us a percentage, and we could not calculate the percentage given the size of information provided to us. And another 4 were excluded simply because we just didn't have enough information as well to appropriately classify those individuals in a given stage, strata. So those 4 individuals were very interesting because these were individuals who had 100% uric acid stones and later found to have a highly impure stone, as I've defined below. So first we looked at this group and we stratified them on a continuum, and that's what you see below here. We have captured the highly pure group, which is characterized as those patients that have all stone analyses that are greater than 100% uric acid. The moderately high uric acid group are those individuals who have a stone that is 100% uric acid composition, and one additional stone that is somewhere between 50 and 99% in uric acid composition. The moderately pure individual are those individuals who have all stone analyses with a uric acid composition between 50 and 99%. As you can see, that represents the bulk of our study cohort. And when we look at our individuals who have lesser degree of uric acid composition, we stratified them as moderately impure if they had a stone composition between 50 and 99%, but another stone with a uric acid component less than 50%, and also defined those individuals as highly impure if they had all stone analyses with a uric acid component less than 50%. So this individual could be someone who had a uric acid component of 10% or 15%. They were classified as highly impure. So once again, I'd like to state that everyone had a uric acid component present here. We then took this stratification and we separated them, as you see above, into the pure uric acid stone formers and the impure uric acid stone formers. And as you notice, we define the pure as those individuals who are at least greater than 50% or greater in their stone composition. Now, the question may be, is that really something valid to do? So here are the data to prove that it is actually valid. So when we actually look at what's going on with these individuals in terms of their hemoglobin A1C, serum sodium, potassium, all those serum chemistries that we actually look at, we see that there's really no difference between any of these groups. So that would indicate that our definition of a pure uric acid stone former at greater than 50%, even though there is a mixed component there, that is a pure uric acid stone former. And I'd like to point out this uric acid level here, which is not statistically significant across the group. Now, there is a little signal here with intact PTH. There weren't as many patients within this moderately pure group that actually had a value. But nonetheless, that's something that would have to be explored for more robust study here. But when we look at those individuals who we have great numbers for, you really don't see any statistical difference between the two. Looking at the 24-hour urine, notably, when you look at the urine pH, there's no statistical difference across the group. They all have low urine pHs ranging from 5.5 to 5.7%, 5.7, excuse me. And most importantly, for the individuals who are most concerned about supersaturations of uric acid, when we look at that, once again, there's no statistical significant difference between the groups. So highlighting once again that biochemically, based on serum studies and urine studies, these groups that we define as highly pure, moderately high pure, and moderately pure, all having uric acid stone component greater than 50%, are similar. And you can see with the uric acid excretion, once again, not significant. Now for the impure group, there's a little bit of a significance that we see in some of the supersaturations for the calcium salts and also pH. That makes sense because there's significant heterogeneity within this highly impure group. Once again, this may be an individual with only a 10% uric acid stone component, or it may be someone with 40%. They're all captured within this group. In addition, and most importantly, when you're looking at the supersaturations of uric acid, you see the impure group, moderately or highly impure, they're the same, as well as looking at their urine excretion of uric acid. There is a difference in calcium. Once again, we would expect that given the heterogeneity of this highly impure group. So at baseline, uric acid stone formers are going to be a little bit older, pure uric acid stone formers than impure stone formers. They're also going to be a little bit more obese, and there's not any statistical significance difference with respect to race, ethnicity, sex across the group. What I like to point out is that when we do look at sex, which has also been previously described as pure uric acid stone formers being more male predominant, of course, yes, we see that here. These ratios versus the pure uric acid stone formers versus impure uric acid stone formers are preserved. This is a 2-to-1, a 2.1 ratio. This is a 1.8. When I look at the metabolic profile of these individuals based on their medical history, we see that there really isn't any difference among these pure and impure uric acid stone formers, with exception with respect to CKD. So this is a only statistically significant finding that we have regarding some of these comorbid conditions. And we see that those individuals with CKD are 1.5 times more likely to actually be pure uric acid stone formers. Interestingly, gout, which people love to talk about, yes, there is a 1.5 times more likely to actually have gout in a pure uric acid stone former. However, there's no statistical significance here. And here's the hazard plot just to emphasize what I just said. So we did note that pure uric acid stone formers have a lower GFR than impure uric acid stone formers. And the mean GFR in this group was about 75 milliliters per minute, and also versus the 84 of the impure uric acid stone formers. That's the only finding that's statistically significant where we're looking at all the blood chemistries comparing the pure versus the impure group. That would be consistent with prior studies that actually identify those individuals with uric acid as having a lower eGFR. Now, when we're looking at the urine chemistries in terms of volume, pH, creatinine, supersaturations, we do see that there is a statistically significant difference between the two groups with respect to calcium salts and also this protein creatinine ratio that rate, that I'm going to point out a little bit later. However, once again, when we're looking at supersaturation for uric acid, we really don't see a difference between the two. So this really argues against the use of urine supersaturation as a mean of diagnosing those individuals with uric acid stones. Instead, we should be focusing on supersaturation of calcium salts. Now, the pure uric acid stone formers do have increased markers of protein excretion. And this has been, these odds ratios are adjusted for age, sex, race, ethnicity, and BMI. And so what we see is that we have an increase in UUN and sulfur, and we see this to be true in the absolute values and also when we normalize these values to creatinine for standardization. What we would expect to see is there's a difference in calcium between the groups, so it's nice that we actually notice that. So when I actually look at these groups and actually look at the odds ratio of them actually having protein excretion with respect to the age, sex, race, ethnicity, BMI, and CKD, we also find that protein excretion is increased independent of CKD. So when I'm comparing the pure uric acid stone formers versus the impure uric acid stone formers, I find in absolute and also normalized terms that urine urea nitrogen, urine sulfate excretion are significantly increased in those population of pure uric acid stone formers versus impure uric acid stone formers. So what this indicates is that those individuals who are pure uric acid stone formers have an increase in dietary protein intake that is increasing their risk of uric acid stone formation. So here is a nice graph of these significant findings when we are adjusted for all of the factors that I mentioned above, including CKD most importantly. And we find that for each 100 milligram per gram decrease in citrate, that increases the odds of a pure uric acid stone former. And for every 0.1 decrease in pH, we also have an increased risk for having an individual to be a pure uric acid stone former. We also know that for every increase in sulfa by 3 milliequivalents, for those people who are used to looking at these urine studies, and also an increase in UUN by 1 gram, and PCR by 0.1 grams, there is a significantly increased odds of actually being a uric acid stone former. So this becomes important because, as I said, there really aren't any great dietary guidelines regarding these uric acid stone formers. And so this indicates that with the increased risk, we should actually focus on getting these patients to decrease their dietary intake of protein, but not so much focus on some of the other dietary guidelines that we actually offer to those individuals who are calcium stone formers. So here I recap some of the findings here, just emphasizing that the pure acid stone formers are 1.5 times more likely to have CKD versus those impure stone formers. So management recommendations based on these data. Pharmacologic, these data support the use of citrate-based alkalinizing agents, but we don't have any clear indication if we should be using xanthine oxidase inhibitors based on our data. And really, we did not have the ability to really search for this. This would have to be looked at a little bit more prospectively. So where is the basis for this, just to kind of review this? This comes out of the DeVries study from 1966, and I think people really need to capture why we're actually using allopurinol uric acid stone formers. So this was a group of 7 patients that actually had a history of uric acid stones. He decided to give those individuals allopurinol after decreasing their alkalinization agents, completely stopping it, maintaining a high fluid intake that wasn't defined in the study. And we see that those individuals, after these specified years of being followed, a lot of them did not have any recurrence of stones, except for 2 individuals. But once he stopped their alkalinization agents and gave them allopurinol of the various doses that are listed here, plus the high fluid intake, you really didn't see much difference in stone formation as you did with the alkalinization. Here we did have an individual who actually had a stone that was actually apparent on X-ray, indicating that there's a little bit of calcium component to that stone as well. So only 7 people, low evidence, great evidence for use of allopurinol and calcium-based stones, but not so much for uric acid stone patients. So at this point, we can actually just say that our fluid intake for the patient should be enough to produce 2 liters of urine daily. An alkali diet should be prescribed that is actually low in animal-based protein, high in fruits and vegetables. And there should be a nutritionist-guided decrease in sulfur amino acid intake. So we do know that increased sulfur amino acid intake does a couple of things. It does impair uric acid excretion, and it also increases the risk of having increased adiposity and also insulin sensitivity. These individuals with uric acid stone formation, they're actually known to have significant metabolic syndrome and also association with uric acid stones and metabolic syndrome independent of one another. So theoretically, if we target the sulfur amino acid and restrict that in a manner, that we can actually hopefully decrease the uric acid stone recurrence in this patient population. So one thing in looking at this uric acid stone cohort, we actually saw that about 10% of the patients, 70 patients actually demonstrated stone conversion. So stone conversion was observed to be bidirectional with respect to pH, meaning an individual may have initially presented with the uric acid stone, subsequently presented with a calcium stone, or vice versa. So given that interesting finding of this from the study, it actually piqued our interest in looking at stone conversion in general. So how common are these stone conversions? What are the risk factors for stone conversions? So these are the data that were actually presented at the AUA 2022 here by our research associate. And what we did is look at this converter cohort population of 10,000 patients and also defined a recurrent stone former as those individuals who had stones, multiple stone analyses that are greater than 90 days apart. Previously, this had been defined by another study about 120 patients, and there's a controversy whether we consider 120 versus 180. We chose 90 based on the data in our registry. Our data in our registry supported that the conversions were happening at least 90 days apart. And you can see that that's about 30% of our patients that actually demonstrated that. So given the stone conversions are present, we actually chose to look at these initial stone formers who had calcium oxalate stones because we have the most robust data concerning this group. And we found that this was about 66% of our population. We did exclude some individuals who converted to other stones. It could be a myriad of other stones, ammonium urate, struvite. The numbers are small. We just don't have the power to evaluate that. But it does emphasize that these individuals with calcium oxalate stones are converting to any different type of stone, okay? We then looked at this control CO group that has recurrent stones, just of CO, calcium oxalate, and we looked at the conversion of CO to CP that recurred with the CP stone after their initial CO stone formation, and also those individuals who converted from CO to UA. I do want to emphasize that there were interconverters that were noted here. The numbers were small and we're really not powered to do the statistical analysis that should be done for those interconverters, but it's something that we should be considering. So in the future evaluating. So the stone conversion, as I said, this is just defining, for example, what a stone conversion may look like. An individual starting off 80%, 20% calcium oxalate, uric acid mixed stone, but 90 days later, you see the pathophysiology is actually different. So what we find at baseline for this patient population using the control recurrent CO stone formers as our reference group is that those individuals who convert from calcium oxalate stones to calcium phosphate stones are more likely to be female, and they are more likely to be Hispanic in ethnicity. There was no difference otherwise with respect to BMI or any of the other markers that we typically will adjust for in the studies. Also, those individuals who converted from CO to CP were more likely to have recurrent urinary tract infections. That makes sense given that we're looking at a greater female population among these converters from CO to CP. When we look at the individuals who convert from CO to UA, we see that those individuals are more likely to be male versus our CO group, which is consistent with what we see in general with our uric acid stone formers. And also these individuals have more stone episodes in general. And that also would make sense given that these individuals do present with a metabolic syndrome, and we discussed some of the pathophysiology as to how metabolic syndrome may be contributing to a uric acid stone formation. But what's interesting to point out that's not statistically different between the group is just the time of conversion. So as we mentioned before, is that there's an 11% chance that someone's going to recur with stones within 2 years of presentation. These conversions are happening on the order of 2 to 3 years. So it does make it important for us to actually get that stone when they present again for an intervention within 3 years of their initial presentation. It may not be the exact same stone. So the lithogenic risk factors for conversion were evaluated. And what we found is that in those individuals who are converting from CO to CP, they did have a rise in their urine pH. And those individuals who were converting from CO to UA did have a decrease in the UA. There were no other significant findings that we could find on urine or serum studies concerning the CO to CP conversion group. However, those individuals with the CO to UA conversion, we actually found quite a few findings, which are actually consistent with what we saw in our uric acid study cohort. So in general, these individuals who are going from CO to UA are going to demonstrate a change in their supersaturation for calcium phosphate. We actually see it decrease. We also see a supersaturation for uric acid actually increase for those individuals. When we look at urinary calcium excretion, as expected, there is a decline in urinary calcium excretion for those individuals who are converting from control CA to UA. And that's either absolute and also normalized terms. So in summary, regarding this stone conversion population, we understand that stone conversion is very common among our current stone formers. We understand that some risk factors for CO to CP would be those individuals who are female, Hispanic, recurrent UTIs, and also pH greater than 6. Those individuals who are going to convert from CO to uric acid are more likely to be male, have more stone frequent events, lower urine pH, lower supersaturation for calcium phosphate, higher supersaturation for uric acid, and lower urinary calcium excretion. So now, as I mentioned before, is this relationship between CKD and nephrolithiasis has not been well elucidated. There have been some studies that have actually come out of the urology literature that have looked at some urine chemistries to define which factors are going to decrease over time in this patient population as they have a decrease in GFR versus which factors are going to increase. However, the studies have not been consistent among those investigators in the past. We do not know what direction the CKD and nephrolithiasis relationship has. So meaning we do not know if this is CKD primarily that's influencing the stone disease or the presence of the stone disease that's influencing the development of CKD. So we look at our patient population again, and we identified those individuals who actually have stone chemical analysis and also a 24-hour urine analysis within 1 year of that baseline stone presentation. And we stratified those individuals into the various groups of CKD as standardly defined. Now, I would like to point out that this group of CKD stage 3 to 5 individuals, this is a group that even though we're representing all the later CKD stages, it's heavily represented by the CKD stage 3 patients. So only 2 CKD stage 5 patients are represented in this group, and only 15 CKD stage 4 patients are represented in this group. So when evaluating the baseline characteristics here, we do see that with respect to age, we have a older group, of course, with the more advanced CKD. That makes sense. They're also more obese when we're looking at the advanced CKD players as well. When we're looking at the sex of the individuals, we see that across the board, with the exception of CKD stage 1, the patients are more likely to be male. So interestingly enough, more likely to be a stone former of CKD stage 1. Looking at the race of these individuals, we see that these individuals are more likely to be Caucasian, which is consistent with prior studies. The ethnicity of these individuals do differ in the sense that when we see the across the board of all the stages, we see that they're more likely not to be Hispanic as well. However, the CKD stage 1 group is actually demonstrating a little bit more Hispanics and also calcium phosphate stone formers in that group, as we noticed before. So with respect to all of these conditions that actually cause a metabolic syndrome, we're seeing that those are positive for those individuals with the more advanced CKD stages. And the issue of migraines is more prevalent in those individuals with CKD stage 1. Note that is a more female heavy population as well. Now, I would like to say that we have used migraines also as a surrogate marker for whether or not an individual is receiving topiramate. So we noticed that the percent of uric acid stone formation does increase with progressive CKD. So initially in our CKD stage 1, we see that the calcium formation of stones, either calcium oxalate or calcium phosphate, is much more significant versus our stage 3 to 5 players here. So this is consistent with what has been previously demonstrated, that those individuals with a lower GFR are more likely to demonstrate uric acid stone formation, and also consistent with our previous data here. So once again, I'd like to emphasize, though, is that even though we see a greater proportion of uric acid stone formers in CKD stage 3 to 5, still the predominant stone that's being made in this group is the calcium-based stones. So supersaturations do vary significantly based on CKD stage. So we see here that when we're looking at the supersaturations for calcium oxalate, they're more likely to be higher in CKD stage 1, as well as the supersaturation for calcium phosphate. Supersaturation for uric acid is more likely to be greater in CKD stage 3 to 5. All right. Now, what's interesting and consistent with the prior uric acid data that I've demonstrated is that the protein catabolic rate representing protein intake, it does not significantly differ across the CKD stages, consistent with me demonstrating that protein intake is influencing uric acid stone formation independent of the CKD finding. So here are the 24-hour urine evaluations for our CKD stages. You'll find CKD stage 1, CKD stage 2, and CKD stage 3 through 5 across these various groups. So consistent with previous studies, we found that there's a lower urinary calcium, a lower urinary citrate, a lower urinary uric acid, urinary phosphorus excretion in the individuals who have a lower GFR. What is not consistent with previous studies is that we do not see a decrease in oxalate, but this has been controversial. So Cadlin had looked at this and actually found that oxalate actually increased with a decrease in GFR, and we see the same thing, clinically significant. With Cadlick's study, he actually found that there was an increase in magnesium excretion as we had advanced CKD, but we actually don't find that. I would like to point out that all of our values are normalized to creatinine here. His study actually represented some absolute values. So there's no significant difference with sodium or potassium across the board. So to look at the impact of CKD to determine the independent effect of that on any given urinary lithogenic risk factor, we created several models here for evaluation. So in our first model, of course, we looked at age, sex, ethnicity, BMI, and our standard parameters of urinary chemistry variable. Subsequent models, we actually looked at all of these metabolic risk factors that will be associated with any particular stone disease, or just in general, or especially anything that's going to drive a stone that's going to form in a more acidic environment. And then finally, we actually looked at the percent calcium to control for that across the CKD stages. And so in doing so, what we found is that the odds of CKD based on your 24-hour urine chemistries are actually increased for every 0.1 unit decrease in urine pH, every 10 unit decrease in urinary calcium, significantly for every 100 unit decrease in citrate, and for every 100 decrease in uric acid, and for every 50 gram decrease in phosphorus. So for the individual who you're looking at for their 24-hour urine study, theoretically, based on these data, you can actually just look at their 24-hour urine chemistry and say, based on that, that this individual is more likely to develop CKD based on the presence of a lower urinary calcium, a lower pH, a lower citrate level, a lower uric acid level, and a lower phosphorus level. So, of course, with that finding, the question is, how do the medications that the patients are taking are actually impacting what we just saw? So if for someone receiving a urinary alkalizing agent, of course, that's going to adversely affect the pH measurement. And, well, it's going to affect like citrate and potassium. So we looked at the patients and how they're receiving their uric alkalizing medication, whether or not they were receiving treatment or not treatment. Of course, most of the patients in our study population were not actually receiving any urine alkalizing medication. And when we actually compared these individuals across CKD stage, we did not see any difference across the board with respect to all the factors that I've already described in terms of the 24-hour urine chemistries. What we did see the difference in that was previously described when looking at the odds of increased CKD with respect to pH, citrate normalized, and potassium normalized to creatinine. We find that pH was not adversely influenced by the presence of a urine alkalizing medication. Citrate was not influenced by the urinary alkalizing medication, but potassium was. So that small signal that we were seeing in potassium at this point, we think it's being primarily driven by the presence of potassium citrate in this patient population. However, these medications are not driving the impact of what we've seen otherwise. Yet, of course, the urine alkalizing agents that are being prescribed is very low in numbers, basically, across the group. So in summary, we find that as CKD progresses from an early stage to a late stage, there is a change in your risk from calcium stone formation to an increased risk of uric acid stone formation. However, that change in your risk does occur independent of the fact that there is a decrease in urinary citrate excretion, a decrease in urine pH, a decrease in urinary calcium excretion, decrease in phosphorus excretion, and decrease in ammonia. So that's important to point out, given that we expect that there's going to be a decrease in melanogenesis and a change in these factors just based on the presence of advanced CKD. So what this indicates to us that we actually need to create more strategies for treating these individuals, not just based on their stones, but also based on their stage of CKD. So it doesn't matter, once again, if they're a calcium stone former and a urinary factor is associated with the calcium stone formation. CKD independently affects that factor and modulates it in a way that it makes it a little bit different, and we have to pay attention to how we're actually going to approach that patient in our medical management. So to sum up, we've got this wonderful biennium. We actually presented the 2002 poster presentation at NKF with these data. I mentioned there was the AUA 2022 podium presentation. 3 manuscripts are going to be submitted this month, and also a research letter is in progress. So future directions for this cohort. This is a nice comprehensive slide made by our research associate that really describes some of the future directions in which we'll go for this. So there's a robust data set for us to actually explore medication effect, such as the SGLT2 inhibitors in kidney stones, look at kidney stones in pregnancy, which has not been well researched, really get more data concerning these struvite stone patients, and see if there's a significant difference in using these 24-hour urine studies in our management tools. We tend to prefer what Lithogenic because it gives us more robust data, but it's really interesting to see whether or not their supersaturation profile information is actually more clinically useful for us than the supersaturation profile. Both are proprietary calculations to determine those information. So I'd like to acknowledge everyone who's been quite instrumental here in actually assisting with this the uric acid study, the CKD study, and also the converter study, and helping with the registry at all. And especially thank you to the Department of Urology, without which we would not be able to really do this study. But we're so grateful for the funding. All right. So with that, I'll open it up to any questions or comments.
Leslie Rickey. I don't do any stone work. I do female pelvic medicine, but really great work. So congratulations. I think you've shown like how much databases and how to collect numbers, what we can do with our own patient data. I was wondering, you mentioned it's labor of love, and I know databases are hard to create and maintain. And I may have missed, but in terms of like funding, how is it conceptualized and created?
So we're using the Yale University funded REDCap. And so a lot of the data entry just happened manually with the Yale Nephrology Clinical Research Program, helping to provide payment, and also the Department of Urology funding the research associate. That's actually helpful for getting this done. And also using JDAT as part of the tool that we're allowed to have access to really help automate some of the data that's going in.
And another question I had, because I know like some of, just like the work I do, a lot of the initial steps are like lifestyle, behavioral, and interventions that aren't necessarily captured by pre-populated data fields in EPIC. And so does JDAT or our EPIC system allow for any like natural language processing or ability to capture some of those recommendations?
So it does. So we can actually pull up some words within JDAT and capture that information. But I'll be honest, we actually use Dr. Levingson's help to actually create nice expression programs so that we can actually import this data into the database as well.
Great. I might touch base with you offline if that's okay. I'd be interested in doing the same thing for our division, but it's just very overwhelming. So I'd love to learn best practices. Right. So it can live like either in the assessment plan, sometimes it gets put more in the patient instructions. And so for some of these lifestyle things, like you have to think, I mean, ideally, well, prospectively, you can definitely capture them, right? But retrospectively,
Can you speak to kind of how we are able to, just so everybody understands, utilize the data, the information from the 24-hour group to how we look at it to interpret what the protein intake of an individual is, just because that amongst the urologists that might be a little bit more lost.
Right. So when we're looking at the 24-hour urine, we're actually looking at three components to really give us, well, there's four, but three main components to give us idea what protein intake is. So number one, we're looking at urine urea nitrogen. Number two, the protein catabolic rate. And number three, the urine sulfate excretion. And number four, a little bit minor, but that's more nuanced, we'll be looking at urinary phosphorus. Okay. And so those individuals who are going to have a higher amount of, a greater amount of UUN, you're seeing a UUN level that's greater than 10 grams. That's going to indicate that there's a higher load of protein intake coming into the individual because all the protein is going to be broken down to a nitrogenous product, basically, that's going to be excreted. And so that protein catabolic rate, of course, we're targeting a specific protein catabolic rate based on the presence, the type of stone that the individual has. So individuals with 15 stones, we're going to actually want them to have a decreased protein catabolic rate to 0.7. So we're minimizing the impact of protein excessive intake on their stone formation. Otherwise, individuals should be targeting a PCR that's about a 0.8 to 0.9, depending on the stone former. And so if we're seeing anything that's elevated above that, that's indicating that there's increased protein intake, and we want to address that. Now, what these two studies that I just mentioned, test on 24-hour urine, they do not help us clarify whether the protein intake is really coming from plant-based protein versus animal-based protein. We cannot distinguish that based on the UUN and also the PCR. However, that's where the urine sulfate excretion comes in, and phosphorus can be helpful depending on how the urine sulfate looks. Because of course, some phosphorus is great phosphorus is coming from fruits and vegetables. So looking at the urine sulfate excretion, if we're seeing a sulfate excretion that's greater than 30 milliequivalents, we know that most sulfate is coming from sulfur amino acids that are derived from meat products, but there certainly are some sulfur amino acids that are derived from plant products too. Anything that's going to be a little bit higher in purity tends to have a higher sulfur amino acid-based content. And so when we see that, and plus sources of protein intake that are coming from supplemental shakes, which are actually adding amino acids, there are also bars that are adding amino acids, it's indicating to us that they're more likely to have an excess dietary protein intake that's coming from either the animal source plus a man-made source.
Yeah, nice talk. This may be a little bit of the weeds, but I noticed that I always thought that at least I remember being taught that magnesium was a stone inhibitor, and I noticed that in one of the graphs it goes down with CKD. Is that true? Is that significant? I mean, does that play a role in stone reformation or formation? My second comment was that have you guys considered, in terms of looking at future cohorts, spinal cord injury patients? I take care of a lot of them who have significant, they have significant, at least as my understanding, risk at developing. So.
No, I hadn't actually decided to take a look at them, and actually, we actually don't have spinal surgery patients or just that diagnostic injury, or that diagnostic code, in our registry.
Yeah, maybe something to look at, because I know Denise is taking and Bruce taking care of a lot of my patients. So that
We definitely put some of the registry.
yeah, I mean, I think that's
we're not marking them yet, so we'll definitely have to do that.
It would be really interesting to see what they're. I don't think, at least to my knowledge, many of them get this type of evaluation with 24-hour urine.
Right. Yes, that's something that we definitely do.
So the magnesium thing, is that
so
real?
The magnesium thing, yes. So magnesium is helpful to preventing stones. However, that's known only with respect to calcium oxalate stones. So we have no evidence that magnesium is going to actually prevent any other type of stone formation.
The SCI patients are tough to get 24-hour urine.
Was it because of the catheterization or
Yeah.
infection and all that? So most of them aren't diverted now. But they, a lot of them have, some pubic tubes. But many of them are on intermittent cath. I mean, I don't know, does infection, do white cells, bacteria and all that play a role in 24-hour urine?
Yeah.
It's really incontinence. If they're capturing it all.
Well, many of them are incontinent. Something to consider.
There also seem to be infection stuff.
Do they?
It's true white stuff.
So your the uric acid stone formation stratifications, that still seems pretty arbitrary to me. The question is it sounds like those analyses were after the fact. So have you tried any different cutoff points and see any differences with the stratification system?
So we did not try to actually stratify them more specifically because we just didn't have the numbers with respect to a number of uric acid stone formers who would have something like 70% to 100%. It really falls off. So that was actually done. What you're describing here, Cadleck actually looked at that, and he did find that the true 100% stone former small study did have an increased serum uric acid, but he didn't really evaluate anything in a lower pH, of course, but he didn't really evaluate anything in greater detail. So he has the best study to look at that with the best numbers actually for stratifying. We're very heavy on that 50 to 60% range, so we're not able to do so. So yeah, the best we could do is 100% versus 50 to 99%.
You have a bioinformatics component, somebody that's helping you do all the bioinformatics analysis.
No.
Because the other way to do it is not to categorize them in groups at all, but to just allow each number to run as a random variable and then ask all the other data, using like a random forest search or something, what aligns with the highest groups versus lowest. You don't put them into buckets at all. 92%, doesn't matter what the number is, it's just the higher the number, what does it correlate with? You basically run this kind of continuous analysis called random forest. It might give you correlations that don't come out with your bucket. You need a biostatistics person.
We do need a biostatistics to that. The other limitation to that is that analysis of the stone components are not consistent across a given lab. So some labs will not give us nice breakdown of percentages versus others will. And looking at this retrospectively, though we are very heavy in the group ARUP labs, it doesn't give us a nice percentage breakdown like some of the other labs.
20%. It's always suboptimal. Might help you get the Isaac's concern that the buckets might be forcing you to align data that doesn't necessarily turn out to be functionally correlated. Example bias.
Yeah.
That was great. Awesome.